Hello, everybody. Welcome to our webinar. We are talking today about clubfoot recurrence. The treatment concept for congenital clubfoot has experienced a major shift towards a more conservative, non-surgical approach, like everybody knows. Nevertheless, recurrence still occurs, and the definition of early and late recurrence are poorly described in the literature. There is currently no consensus among experts how and when to address a recurrent clubfoot, and we would like to look a little bit closer into this stage of clubfoot treatment, and are very thankful and delighted to learn from three experts in the field. We welcome Adjunct Whitlock, John Herzenberg, and Vincent Moskwa. Thank you so much for contributing to our webinar. We really appreciate your efforts and for being with us today. The experts are going to take questions by the end of their talks, and we are looking very much forward to what they have to say. We also would like to thank OrthoPediatrics for supporting our event, which we start now. So warmly welcome to our webinar about clubfoot recurrence.
Good morning, everybody. I'm Vince Mosca from Seattle, and I was very pleased and honored to accept this invitation to speak to my good friends on the other side of the pond. And it's a very interesting topic. I'm glad that I'm sharing the stage with the people I am. In fact, some of you may know that John Herzenberg and I trained together in our residencies at Duke University, where our chairman, Dr. Goldner, said that the definition of a clubfoot was congenital equinocaval that required surgery. And if a clubfoot did not require surgery, in that it responded to casting, it wasn't a true clubfoot. So for John and myself to have adopted the Poncetti method, that was a huge jump for both of us. I have no financial disclosures for this talk. I want to start with definitions, because I think at the crux of this whole issue is, what are we talking about? The management of early recurrence in Poncetti-treated clubfoot deformity. So what is a deformity? Oops, there we go. So what is a deformity? Well, a deformity of a bone means it's misshapen. It may be angulated or rotated, or in a case of a fraction malunion, it may be translated. A deformity between bones, for which clubfoot is the poster child, deformity is normal or near normal bones that are not aligned anatomically. And that's in contrast to a malformation, meaning made wrong. I have 5 categories of malformations: too large, too small, too many, too few, and failed to separate. So a clubfoot is clearly not a malformation, but in truth, because we can't make malformations normal, they were made wrong. What about a deformity? Can we make deformities normal? And the answer is no. We can make them near normal. We can achieve goals such as comfortable, looks pretty good, works really well, but we can't even make deformities normal. But that's the attempt. And what we've learned, especially from Dr. Poncetti, is that the less surgery we do, the better we can achieve those goals of not normal, but near normal. What about the definition of recurrence? So recurrence means to reoccur or happen again. Dr. Poncetti's favorite term for this was actually relapse. And relapse from the dictionary means deterioration back to the original after a temporary improvement. So even though these words are slightly different, they both start with RE, I think they're synonymous, and I'll go back and forth between the two terms. I actually like relapse a little bit better than recurrence. A basic premise in all of this regarding clubfoot management is based on clinical research, not bench research. And the premise is that capsular release surgery, like posterior medial release or posterior medial lateral release, is bad. It leads to pain, stiffness, and long-term disability or dysfunction. On the other hand, joint-sparing surgery, like tendo-Achilles tenotomy, extra-articular anterior tibial tendon transfer, those things are good because they have been found to lead to comfort, flexibility, and long-term good function. The reality is there is no known treatment. Since Hippocrates first talked about clubfoot, 400 BC, there is no known treatment for clubfoot deformities that is a panacea in that it guarantees the achievement of full deformity correction and long-term maintenance of that correction. The other reality, though, is that capsular release surgery not only is bad, but repeat capsular release surgery is worse, and re-repeat capsular surgery is terrible. How often does recurrence or relapse occur? Well, in the literature, I found between 31 and 56% of club feet have recurrence or relapse, whichever word you like. But there's no scientifically supported data on what the true incidence is, and here's the reason. We don't know how to define recurrence or relapse. If I find that my child, my baby, that treated for clubfoot, has 45 degrees of ankle dorsiflexion at 1 year after the tenotomy, and then at 4 years, when I'm ready to stop the foot abduction brace, they have 10 degrees, is that a relapse or recurrence? Are you happy that they only have 10 degrees of ankle dorsiflexion at 4 years? Am I? What is the cutoff for what is recurrent? It's a relapse because it's not 45 degrees anymore, it's 10 degrees. So is that a relapse? Is that recurrence? Or is that the natural history? And does that lead to good outcome? We don't have a definition. Another problem with this is that recurrence implies initial full correction. We don't really have data to say that we have full correction. We think we do, but there may be apparent full correction that actually could be incomplete correction. So that a year or two later, what looks like recurrence by my definition or your definition might actually be persistence rather than relapse recurrence. And finally, we need to continuously remind ourselves that recurrence applies to the structural deformity, not the muscle imbalance that a large percentage of kids with clubfoot have. So recurrence means that either the cavus, the adductus, the varus, and or the equinus reoccur by whatever definition of recurrence you have in your practice and in your mind. Muscle imbalance, again, is not objectively defined, but the reports and literature say that between 38 and 54% of club feet have muscle imbalance. The tibialis anterior is strong, and the peroneal muscles are weaker than normal. But again, if they have muscle imbalance, it's not recurrence because it's not a deformity. It is an inherent dynamic feature of some club feet, maybe up to 40%. So we cannot influence that any more than we can influence the equino-cable varus foot deformity in a child with cerebral palsy. Kids with hemiparesis often develop equino-cable varus foot, which is, I guess, if you will, an acquired clubfoot deformity. It has all the component deformities of a congenital clubfoot, but it's not congenital. It's due to muscle imbalance. So in those feet, in those children with cerebral palsy, we can perform serial casting if they're starting to develop deformities. We can temporarily maintain the correction with full-time bracing, but the structural deformities will often recur when the children get older because the muscle imbalance leads to that event. When I see kids with clubfoot, I think of three features: the shape, the flexibility, and the muscle balance. Shape and flexibility are deformities. Muscle balance is something else. We can achieve good shape and good flexibility with manipulations, casting, and in about 90 and 95% of cases, a tendon Achilles tenotomy. This is taking advantage of the viscoelastic properties of collagen. Creep, for the 30 to 45 seconds, we're manipulating the foot, we're stretching the collagen to the extent that it will at that point in time. And there's a finite amount of stretch that collagen will undergo using the property of creep. Then we apply the cast at the limit of stretch. And during the next several days, by the process of stress relaxation, the collagen elongates further so that when the cast comes off, the tendons and ligaments are longer, the foot looks better. It's a longer rubber band. Then we apply creep again, followed by stress relaxation. Now that works extremely well in infants. It works less well in older children. And it's probably a gradation of time where these viscoelastic properties are not as successful as the child gets older, but they still work. You can stretch your Achilles tendon by putting your hands on the wall and leaning back, and you'll stretch your tendons even now. There's one other biologic property that goes on when we're doing clubfoot casting, and that's the Bulkman principle that Shafiq Peroneus showed so very well in his MRI study, that when we're doing the casting and manipulations, the cartilage onlog with little ossification of those onlog, they'll change shape. So in the infants, we're doing creep, stress relaxation, and cartilage molding. If we do serial casting of older children with larger ossification centers, this probably plays less of a role in deformity correction for recurrences. And then we maintain the good shape and flexibility with braces and maybe with stretching. And then there's muscle imbalance, this inherent feature of some club feet. No doubt they're genetically different, and it accounts for about 40% or so of kids with club feet. Can we avoid recurrence and relapse? Well, if children don't wear any braces after the final cast is removed, there's probably 100% risk of recurrence. But there are some non-compliers who don't recur. And what we can say based on the number of recurrences by anybody's definition is that the foot abduction brace decreases but doesn't eliminate relapses. It is the hardest thing to study because it's so hard to know how much time the children are actually wearing the brace. With really reliable parents who tell you, I know this is what I'm doing, we still don't really have a way of measuring compliance. And so this is a variable. We know bracing is better than no bracing. And is there a role for stretching to decrease recurrences and relapses? Probably so. The French method came up pretty close in comparative studies with the Poncetti method. The Poncetti method showed superiority, especially in that large study from Dallas. But I think Alain Demeglio and others who use the French method often in their practices will admit that there's an advantage to using stretching manipulations, maybe with therapists, maybe with parents, in addition to the bracing after full correction of clubfoot deformities. Does muscle imbalance cause relapses? Well, it certainly may. Remember, muscle imbalance is not the relapse, but if muscle imbalance, like in children with cerebral palsy, if the muscle imbalance creates structural deformities, then yes, muscle imbalance can cause relapses, but muscle imbalance itself is not the relapse. It's an inherent feature of that club foot. And in these feet, you can see when the child's standing plantigrade, those are beautiful looking feet. Stand on your heels, and you can see the dynamic supination. Here's another child standing on the heels. It looks dynamic, but when the child's foot hits the ground, there's a dorsal bunion. So there's some structural deformity in this foot as well as the muscle imbalance. Well, that was most of my 15 minutes, and now I'm going to get to how I treat it, because I think that's the easy part. The hard part is to know when to treat or how to even identify a relapse. Well, if serial casting worked in the first place, and we'll assume it did, and that what looks like a recurrence is a recurrence or relapse and not a persistence, then serial casting, creep, stress relaxation, and depending on the age of the child, probably some cartilage remolding and modeling as well by the Hutter-Bulkman principle. As from infancy, the cavus, adductus, and varus will frequently respond to casting, and the tendo-Achilles might not. So there may be a need in the first few years of life to perform a repeat tendo-Achilles tenotomy. And these are tenotomies, these are not lengthenings, these are percutaneous, cut it in two. That means tenotomy, not lengthening, not TAL, it's a TAT. And then the child has to return to bracing. If there was a recurrence, it would just be natural to think that unless the child was braced with the best bracing protocol ever, that there would be a relapse or recurrence. And then follow the children frequently. Every 3 months I do for 2 years, and then every 4 to 6 months for 2 to 3 more years. If you have longer intervals between follow-ups and they develop a recurrence, then it will take more casts to reestablish normalcy. And I'm not going to say too much about the later relapse. I'll call this the early late relapse, after 3 and maybe before age 5. Serial casting again. You have to start. Dr. Poncetti made it very, very clear that big surgery, capsular surgery is bad. If there's reoccurrence, if there's persistence, if there's relapse or recurrence, start with serial casting. You might not correct the deformities completely, but you can decrease the extent of recurrent deformity, decrease the extent of any more invasive surgery that might be required. Possibly repeat the TAT. God forbid, maybe a TAL with the posterior capsule would be needed. I don't think that's the worst thing in the world, but try to follow the kids closely so you don't have to get to the point where they don't respond to the serial casting. Maybe a plantar fasciotomy is needed for really recurrent persistent cavus. And in this older child, over 3, you might consider if muscle imbalance clearly has been contributing to relapses, that at the time of pre-tendon transfer surgery, stretch the deformities. If they're not completely corrected, add a plantar fasciotomy, another tendon Achilles lengthening, and transfer the tibialis anterior to maintain deformity correction. Excuse me, and then go back to bracing. Principle of foot deformity. Deformity correction does not correct muscle imbalance. Muscle balancing does not correct structural deformities. So when you're considering your child's foot that doesn't look quite right, remember these principles. And remember Dr. Staley, who recently passed away. This monograph, which is in its 3rd edition on Global Health website, has been a tremendous source of information and resource for people around the world who manage clubfoot deformities. Rest in peace, Dr. Staley. And now I'd like to introduce Dr. John Herzenberg, my friend of about 40 years and a true expert in managing clubfoot deformities. I'll stop sharing.
Thank you, Vince. Can you hear me and can you see me? Can you see my screen?
We cannot see you, Professor Herzenberg.
Yes.
Okay. Well, I guess it's because I have my camera turned off. All right. So thank you, Vince. And Vince and I were tasked to talking about early and late recurrences, but it's kind of a Venn diagram. There's a bit of an overlap, so there's going to be some repetition by necessity here. And these are my disclosures. So I'd also like to start by talking about terminology. There's recurrence of deformity versus residual deformity versus untreated. So I define recurrence as a relapse of a previously corrected deformity, and a residual deformity is a persistent deformity that was never indeed fully corrected. And then finally, when you travel overseas to some developing countries, you see untreated, which is the natural history deformity. So I'm going to try to focus really on the first category, not the others. The recurrences can include all of the elements of a clubfoot: cavus, adductus, varus, equinus, everything that we're used to seeing, including supination and internal rotation. Let me just show you by example this, though, and make a point, or make a plea for you all to consider taking x-rays. This is a 6-month-old baby that had atypical feet and now is relapsed or recurred into equinus. So these are the clinical pictures. Now, I will argue that you really need to take x-rays, because when we take x-rays of this child, we can see that the calcaneus is tilted upward just fine. So this child does not need another tendo-Achilles tenotomy. But if you look at the Miri angle, there's a lot of cavus. So what this child needs, in fact, what we did was 8 additional casts using the Poncetti 2 maneuver to stretch the plantar fascia, and then back into boots and bars. And so now you see a nice dorsiflexion in these repeat x-rays made after serial casting, and the Miri's angle has been reduced and the calcaneus is still in a good position. So not all equinus means TAT or TAL. Vince pointed this out: recurrence is very common, 10 to 41%, especially when braces are not used. The dirty little secret that we can't tell our patients is that there are some kids who don't need the boots and bars, but we have no way of identifying which one they are, and so we have to just treat everybody. In my series, I've had about 28% with some degree of relapse. I like to classify them as mild, moderate, and severe. A mild recurrence can be treated by casting, followed by repeat bracing. A moderate recurrence requires casting plus some type of extracapsular surgery, such as a TAL, tendo-Achilles, tibialis anterior tendon transfer, or possibly even an external fixator, because that's really extracapsular. But a severe recurrence requires casting plus intracapsular surgery, what Dr. Poncetti told us not to do, open joint surgery. The most common ages for relapse are during the active years of growth, when the foot is growing very rapidly, between 1 and 4. It's rare to see it after 4 to 6, but I have seen relapses in 6-year-olds out of the blue. If I see that, I'll look for other things such as neurologic issues, maybe even do an MRI of the spine. But this is the rationale for bracing at least 4 years. And I think we should make the poster child for bracing Shaun White, the famous snowboarder, because if you think about it, snowboard is really nothing more than a boots and bar. The factors that contribute to recurrence are non-compliance, as Dobbs has shown in his paper, lower socioeconomic class, and also Marquende pointed out intrinsic muscle imbalance, which is awfully hard to measure, unfortunately. The factors that do not correlate with recurrence are the initial severity, the initial Peroneus score, and the number of casts needed for initial correction. There's too many other confounding factors. So how does recurrence present clinically? In the very early phases, it's a child who is slipping out of the boots and bars. In the toddlers and older kids, it's the kids who are walking on the side of their feet. They have heel equinus when viewed from behind and forefoot supinatus when viewed from the front. And we're used to seeing these plantar lateral callosities, whereas the skin that's underneath the big toe under the met head is soft as a baby's bottom. So they're overloading the lateral side of their foot. And in absence of a petabarograph, we have them walk across our dirty floors, and you see an absence of dirt under the big toe and a preponderance of dirt and other debris on the plantar lateral aspect of the foot. So the initial response, I would agree with Vince, it's always casting. Ideally, it should be long leg Poncetti casts. Sometimes we cheat and we do short leg casts in the walking age child. And for most mild recurrences, 2 to 4 casts is sufficient. But there's no justification whatsoever for observation. Observation is, as this child is showing, she doesn't like being here, so she's closing her eyes and pretending it will go away. So observation, which is, I would include stretching, physical therapy, weight bearing, does not work. It's like hear no evil, see no evil, and speak no evil. You should not ignore recurrences because by itself, it never gets better. Less than 2.5 years, we recast and then go back into boots and bars. Over 2.5 years, we recast, and then we'll consider a tibialis anterior tendon transfer, repeat TAL, and whatever a la carte surgery is needed. What if the recurrence resolves with casting? You go back into the boots and bars. Well, you reinforce the boots and bars bracing protocol, remove any barriers to compliance that may exist, and close follow-up for recurrence and compliance. What if the casting doesn't resolve the recurrence? Moderate relapses over age 2.5, we consider these additional surgeries. For cavus, I add plantar fascia, either superficial or deep. And something that not too many people talk about, but I think Vince and I are doing this more and more, is Peroneus longus to Brevis transfers. If you take the tibialis anterior and transfer it, you have unopposed pull of the Peroneus longus, and that could lead to additional cavus. I personally avoid repeat percutaneous tenotomies. I do it once when they're infants, but a second time is a no-go for me. I'm really afraid about damage to the neurovascular bundle. So if I go back, they're getting an open TAL, not a perc tenotomy. And for severe relapses, I'll sometimes have to admit it, they need to have open joint surgery, posterior release, posterior medial release. Occasionally external fixation that has some limited indications. Now, Vince taught me the 3 scenarios for tibialis anterior tendon transfer. The first one is when you have a well-corrected flexible foot with dynamic supination in the swing phase, and that foot does not need any preoperative casting. The second condition is when you have a mildly deformed foot that first requires some preliminary casting, and that does require, say, a month of casting before the surgery, before your TA transfer. And then third scenario is when you have an Achilles contracture that does not correct with casting, because it rarely does. And in that case, you have to not only cast first, but you may need to add TAL and arthrotomy sometimes. And that's a decision that's made on the table. You're all well familiar with the Poncetti technique. I'm actually using the Garceau technique more than the Poncetti technique because the Garceau gives you a more direct pull. You never do it before you see ossification of the lateral cuneiform. That's why we wait till 2.5 years of age. The results after TATT are not normal. Lori Carroll's group studied this, and she says that the foot is better aligned for a more even distribution of pressure, but it is not normalized. So Vince talked a lot about muscle imbalance, and I agree. Some recurrences are caused by muscle imbalances, and recurrences can occur despite good compliance because of the muscle imbalance. And as I alluded to before, there are some non-compliant kids who never get a recurrence. One of the challenging things is muscle balance is difficult to measure or to document. Where are we going in the future? I don't know. Maybe a better designed boots and bars. Maybe boots and bars with embedded compliance sensors so we see who's really wearing them. And then Yale Gelfer has talked to us about functional electrical stimulation to the peroneals. What's the role of that? So here's an example of a recurrence at age 6 in a child with the initial images. And typically they have plantar lateral callosities. That shows up on the petabarograph. And they can have mild bony deformities. So this child would get preliminary casting followed by balancing surgery. The bare minimum recurrence after Poncetti, if they're less than 2.5, recast, and then back to the boots and bars. Over 2.5, recast, and then consider tibia tendon transfer to the lateral cuneiform, TAL, and plus or minus plantar fascia if there's a cavus component, and consider Peroneus longus to brevis if there's a component of cavus. Occasionally, I do TALs and add a posterior capsulotomy. How do I decide that? At the time of surgery, I do the TAL and then take an x-ray. If there's no improvement, I don't bury my head in the sand. I continue downward and do a posterior capsulotomy. So what are these soft tissue adjunct procedures? I mean, we're afraid every time we do one of these posterior capsulotomies that Dr. Poncetti is going to send down some lightning bolts from heaven and strike us dead because we violated that principal rule. But in my practice, I do this not infrequently. I will not ignore an equinus. I think that equinus correction is important. And if it doesn't happen with a TAL, I don't rely on the fact that it may just stretch out over time. Plantar fasciotomy I talked about. There's also the abductor hallucis tenotomy, medial release, medial plantar release, tibia tendon transfer, Peroneus longus to brevis transfer, and joint distraction with X-fix. All of these are soft tissue procedures that are in my toolbox. Now, we studied the ankle range of motion after posterior ankle and subtalar capsulotomy for relapsed club feet. This was published in JPO in 2017. And we found that if we mobilize these kids within 3 weeks of the surgery, then they maintained the correction that we got. So for this reason, I do not combine an open release with a tendon transfer. If I think I need a tendon transfer, but I have to also do a posterior capsulotomy, I defer the tendon transfer because a tendon transfer requires immobilization for 6 weeks. And if I immobilize them for 6 to 8 weeks, then the joint is going to get stiff. So therefore, in my book, the two operations, arthrotomy and tendon transfer, are not compatible as a single stage procedure. General rules of thumb: no tendon transfer is capable of correcting a stiff deformity. You must first obtain correction using casting, osteotomy, or releases, and then a tendon transfer can maintain that correction. But a tendon transfer can only maintain, it cannot obtain the correction. As the kid gets older, we have bony procedures in our toolbox: calcaneal osteotomies, cuboid closing wedge osteotomy for the metatarsus adductus deformity, medial cuneiform opening wedge osteotomy, the so-called McHale procedure. Naviculectomy works very well in some very severe feet, combined with a calcaneal cuboid fusion. We can use guided growth of the distal tibia for equinus that does not respond to tenotomy, TAL, and posterior capsulotomy. Triple arthrodesis is reserved in older kids. Midfoot osteotomies, supramalleolar osteotomies, and the various Ilizarov U and V osteotomies are all in my toolbox, judiciously used. So in summary then, the Poncetti technique does not equal no surgery. I mean, we know already that very frequently 90% need a tenotomy, and a certain percentage also need a repeat TAL, a TA tendon transfer, plantar fascia, and so forth. So my message to you is don't be afraid to use surgery if casting alone is not sufficient. It is not the ultimate sin to open joints if needed. We are surgeons and we need to judiciously apply our surgical skills. Thank you very much for listening, and I look forward to the discussion. Now I'm going to stop sharing my screen, and the next speaker is going to be Adjunct Whitlox from the Netherlands.
Thank you very much. My name is Adjunct Whitlox, and I am working in the southern part of the Netherlands in the Maastricht University Hospital. And when Stephanie asked me to tell you something about the treatment methods in clubfoot recurrence, evidence-based on the review of literature, I thought, well, this sounds like a mission impossible. And after again studying the literature, I realized it was a mission impossible, since not only because the definition of relapse clubfoot is not completely clear, and on top of that, this evidence-based treatment is not possible in this phase of treatment clubfoot recurrences. As you already heard by the excellent talks of the previous speakers, there are a lot of possibilities and a lot of definitions to talk about when thinking about relapse clubfoot. And the outline of my talk after these two presentations will be again to talk about the definition, to talk about the treatment goals and challenges, to talk about the treatment of timing and the deformity. And unfortunately, all of this is not evidence-based. And in addition to that, I would like to talk a few moments about future goals of our pediatric orthopedic society. So when you think about the recurrence clubfoot, as you already heard, you can talk about the residual clubfoot, the relapse clubfoot, or the neglected clubfoot. And the definitions which have already been provided are quite clear, but there is not one definition which is adapted by the whole society. And that makes discussion about this problem even more complex. So how do we define a relapse? Well, as you already heard, all initial clubfoot deformities present, a tight heel cord, the dynamic muscle imbalance, and the varus hindfoot and the cavus problem. The treatment goals and challenges for patients with the relapse or recurrence clubfoot are really complex, and it's important that you keep in mind the patient needs. You define realistic goals together with the patient. You try to come to a plantar-grade flexible foot, a pain-free foot which doesn't need a high frequency of procedures, and you come to a foot which does not require shoe modification, and you diminish when you treat these patients, you have to realize that there is a diminishing experience with operative techniques as described by our previous speakers, since the current pediatric orthopedic surgeons all come from an area where the Poncetti treatment has been the #1 treatment for clubfoot, and this makes that all kind of operative techniques which were used in the past are not that well taught or present anymore. So a relapse clubfoot treatment should be guided by individual patient needs and functional considerations. So, as we all understood from our previous presentations, the Poncetti treatment is the golden standard and always starts with the manipulation and casting, often followed by the Achilles tenotomy, and very important, the orthosis, which has to be worn as long as possible, but at least up till the age of 4 years. And what is important to keep in mind that a clubfoot has the stubborn tendency to relapse, which is stated by Poncetti himself. When you think about the time frame of the relapse clubfoot, you have the early relapse, the midterm relapse, and the older relapses, which are very uncommon, as already said before. And you can always start with the Poncetti treatment with serial casting, the Tibialis anterior tendon transfer, and the heel cord tenotomy. All the relapse patients have significant rigid deformities, which are a combination of osteotomies and gradual corrections using a frame. You can also start treating the patients according to the deformity. So when you think about treatment your patients with a relapse clubfoot, you can either start treatment according to the timing of the relapse, or you can start treatment according to the deformity of the relapse. And that is what we are now going to talk about. So when you have the subtalar derotation present, you can always start again with the Poncetti treatment, do a soft tissue release, or do aim for a gradual correction with the external frame. When you are talking about the equinus in patients with a clubfoot relapse, you can, as discussed previously, repeat the tenotomy, which can be done till the age of 6 years. You can use the 3-step technique, but it's very important to keep in mind that doing a Achilles tendon tenotomy is a dangerous procedure, and open lengthening procedure might be more easy and more safe to do. The equinus can also be treated by an external frame where you gradually lengthen the different structures. Or you can use guided growth, as now is been used quite a lot in patients with an equinus. However, all these treatments, and I just want to emphasize this once more, are not evidence-based, however. So we can't tell you what exactly is the best thing to do at which time frame and at which deformity at this moment. When you want to treat the cavus of a patient with a relapse clubfoot, there is the observation and grow method, but as already said before, this is not a very wise thing to do, since this will not disappear by itself, and it's not in the patient's best interest to only do an observation. So there is always the place of a fascia plantaris release, a midfoot osteotomy, or also the gradual correction with the external frame. When the adduction is the most important problem, as you have seen in the previous talk, in a flexible foot you can do a TET, or when there is a stiff foot you have to start with serial casting again. When the adduction is present and you can't get to a flexible foot anymore, you can work with a lateral column shortening and a medial lengthening, or you can still use the gradual correction with the external frame. When there is a heel varus present, an osteotomy is in place. In very rare cases, you can do a triple arthrodesis, or you can use the gradual correction with the external frame. When I was invited to talk about this topic by Dr. Boom, I realized that in the Netherlands we also were talking about this topic within our Pediatric Orthopedic Society. Since the guideline was established in the Netherlands, the clubfoot treatment is centralized nationwide to 11 centers. And with these 11 centers, we are currently discussing what we think is a relapse or a recurrence clubfoot. And only by discussing this in your nation or amongst experts around the world, I think we can come to a clear definition of this problem. And since our guideline is in place, our clubfoot treatment is centralized nationwide. And I understand fully that in the Netherlands there is a unique geographical situation, because we are quite a small country, and we have hospitals close by to every patient, but I think it's worthwhile when discussing this complex problem to think about centralizing your clubfoot treatment in your nation. And in addition, I think it's really important that we realize that clubfoot treatment initially, but definitely in relapse, has to be done by experts. As my colleague already told you, there is a toolbox which is extensively filled with all kinds of different surgical techniques, but it is important that those techniques are only used by the people who are very expertised in this. And it would really be interesting to start a clubfoot relapse expert panel in Europe and over the entire world in order to discuss all kinds of treatment options together. And the close collaboration with patient groups in this regard is really important. And in Europe, such an initiative is now starting, and I think this might be one of the directions which we need to go when we want to talk about evidence-based treatment of patients with relapsed clubfoot. And in addition to that, I think the combination of nationwide registers to define the effective treatment strategies might be very interesting for the future, so that we don't end up by using only expert opinions, but maybe we can really define an effective treatment of patients with a relapse clubfoot. I would especially thank my Dutch colleagues who are gathered in the Dutch Pediatric Orthopedic Society, since we are also starting and working on the complex and difficult topic of relapse clubfoot treatment. And as I said previously, we are trying to define and make an algorithm in which way we can start treating these patients the best possible way. Thank you all for your attention.
Thank you very, very much to all of the speakers. Very, very interesting talks. There came up some questions from the audience, which we might going to answer. The first question is to Dr. Herzenberg. How much dorsiflexion is enough dorsiflexion? Is it age dependent, 1 year, 5 years, 10 years, adulthood? Given the normal shape of the talus in clubfoot, is it ever possible to achieve normal ankle dorsiflexion in clubfoot patients? Maybe we start with the first part, how much dorsiflexion is enough dorsiflexion?
So that's a great question, Stephanie, and whoever asked it. Vince and I have talked about this at length. I think one thing we agree on is that you lose dorsiflexion as you get older, even in the normal non-clubfoot side, as we get stiffer and our bones are more settled and the soft tissues are less pliable. So if you're starting off as an infant with only 0 to 5 degrees of dorsiflexion, you are at risk, in my opinion, for losing that. So if I have a child who only dorsiflexes to neutral, I'm not happy with that, because if they lose any dorsiflexion, they are going to be in a bad situation when they're adults. It's not horrible, it's not cancer, but it is, there is a certain benefit to being able to dorsiflex your foot. For example, just as you go downstairs, the trailing leg has to dorsiflex. So I'm pretty aggressive about treating dorsiflexion, so I won't accept 0 degrees. That's not good enough for me. I want 10 degrees or 15 degrees above neutral.
Can I also answer, or at least respond
Absolutely.
to that question? And that is that we talk a lot about how much dorsiflexion we can accept, even though we don't all agree, in the first 4 years of life. And then the next data point that I know of is the 50-year follow-up study that Jose Morquendi and the group published about 10 years ago, where it was a comparison of a large number of Dr. Poncetti's patients. Some had the tendon transfer, some didn't, and they looked at them average age 50, which is phenomenal. It was a 29% accrual of all the patients. So scientifically, it wasn't a great paper, but getting 29% back of anything at 50 years, I'll read the paper. What impressed me, besides all the painless arthritic changes on the x-rays, was that the average ankle dorsiflexion at 50 years was 5 degrees. Well, I'm not an adult foot surgeon, but I know that a lot of my friends who do adult foot and ankle surgery see patients who have metatarsalgia, Achilles tendonitis, they have foot pain and problems because they have limited dorsiflexion. 5 degrees in someone who doesn't have a club foot is not enough for health and happiness, yet it seems to be enough for former clubfoot patients. And so between age 4 and age 50, we don't know what happens to dorsiflexion, but apparently many end up with 5 degrees of dorsiflexion at age 50, and it's okay if you had started with a club foot.
Talking about dorsiflexion, there's a question about guided growth when you have a lack of dorsiflexion or when you're in equinus. People ask if there are any tips or tricks in case there's not that much space. What kind of instruments are you using, or what kind of material are you using? Adjambo, any comments on that?
In our hospital, we use the 8 plates as are commonly used, and actually we use the 8 plates only around the age of 4 to 6, and most often we can place the 8 plates correctly without being too close to the growth plate or too close to the joint. What we do see, however, is that when you look at the x-rays after placing the 8 plates, is that despite the fact that our patients tell us that they have the feeling that they are walking more comfortable, and the parents also can confirm this, on our x-rays we are not always that happy, actually. So I am not completely sure whether this way of treatment is actually establishing what we really want to see, but the patients up till now are quite happy.
I think the person who asked the question wanted to know, in case you have not that much space and you don't get in the 8 plate, even in older kids, any tricks or any advice what to do in case you want to use this method?
I'd like to speak to that. So first of all, the literature on guided growth for equinus is pretty limited. I'm only aware of 3 papers. One says it doesn't help, one says it's kind of lukewarm, and one says it's the greatest thing since sliced bread. So I'm not sure what the truth really is. But when you do use a guided growth in the distal tibia in a very young child, you cannot use, in my experience, the standard 4.5 millimeter cannulated screws. You have to go down to a smaller screw size, like a 3/5 screw or even smaller. And now there's talk about using guided growth for the anterolateral bow in neurofibromatosis and the pre-fractured CPT. So you really need to get it down to smaller implants that the standard companies that offer you guided growth plates are not providing. So you have to improvise every time. Also, when you go down to smaller implants, I would recommend that you use solid screws, not cannulated screws, because a cannulated 4.5 is strong, but a cannulated 2.0 is not strong. So you have to have the whole toolbox available and go outside, think outside the box. Don't just use the standard companies that provide you with 8 plates or PD plates or whatever kind of plates you use if you're doing young kids. I think it does have a role, and it's certainly a nice alternative than doing a supramalleolar dorsiflexion osteotomy. But that's also an option, especially in older kids who no longer are growing, in teenagers, for example. So I think it has a role, but it's yet to be fully defined.
Mm-hmm. Thank you.
And I would say too that if you're thinking about doing it, do it. If I may just, if you're thinking about doing it, do it early, because the distal tibial growth plate grows so slowly that if you wait too long, you don't get much correction. And the alternative of doing the supramalleolar osteotomy, by the time you do the angulation and translation, the ankle looks awful. You may reorient the distal tibia the same way you do with guided growth or with osteotomy, but you have to create such an unusual connection of the bones when you're doing a dorsiflexion translation osteotomy. On the outside, it looks terrible, whereas with guided growth, the ankle looks normal from the outside.
When you say early, what do you mean with early? Very early, immediately when it occurs, or?
No, and I haven't done that many. I've done several, but once the kids get to be teenagers, 12 or 13, even for a boy who's going to grow a few more years, they just don't have time to get much correction. So I would say this is maybe under 10, over something, but under 10.
Under 10. Mm, okay.
Well, I'd like to make a plea that we should be intervening when these kids are still toddlers, and I'll tell you why. If the talus spends all of its time in the plantar flex position, you never get to form a notch in the neck of the talus. And there's a nice paper by Ken Noonan where they did MRIs of babies with club feet and older kids. And that absence of a notch is going to permanently preclude dorsiflexion. You know, the anterior colliculus of the tibia has to go into that notch to dorsiflex. And if you have a flat surface between the head of the talus and the body of the talus, there's just nowhere for that to go. And so when you do, in those situations, if you do a posterior capsulotomy, you get what I call a hinge dorsiflexion. It's analogous to what we see in Perthes disease when you get hinge abduction. You're not truly abducting, you're just hinging on the edge of the acetabulum. And so if you do a posterior capsulotomy and it doesn't have that ability from the geometry to dorsiflex for the talus to go back in the mortise, you get hinge dorsiflexion. And that's not going to be a permanent correction. It's going to fall back, you know, the way it was. So I think the only way we can permanently correct these problems if we address them early. And I think by the time the kids are, you know, 6, 7, 8 years old, it's the horse is out of the barn. You know, your talar anatomy is fixed. I don't know what the ideal age is, but I'm getting more and more aggressive. And if I see kids that are not dorsiflexing, you know, 10 degrees, I'm not ignoring that. I'm being aggressive about that, even to the point of doing, I hope it's a lightning beam doesn't come down, but a posterior capsulotomy of the ankle.
There's another question for Vince. Can you treat muscle imbalance also with a Dwyer osteotomy is the question.
Say that again?
Can you treat muscle imbalance also with a Dwyer osteotomy?
Well, again, what I said several times in my talk is the principle is that there's deformities and there's muscle balance or imbalance, and they're completely different things. So if there's, the only reason for doing a calcaneal osteotomy is if there's rigid deformity that cannot be corrected by soft tissue deformity corrections. If the hindfoot varus is due to inversion of the subtalar joint, one component of inversion is varus, and you have to correct the subtalar joint to normal alignment. You can start with serial casting to evert the inverted subtalar joint. If you achieve full alignment of the talonavicular joint by everting the subtalar joint, then the hindfoot varus should theoretically be gone. In some cases, though, if you do serial casting, you completely evert the subtalar joint. The talonavicular joint is absolutely lined up radiographically. There may still be residual structural varus in the calcaneus, no longer in the subtalar joint, but in the calcaneus. In that situation, then a posterior calcaneus lateral displacement osteotomy will correct the deformity. But a tendon transfer can in no way correct any deformity. They're two different things completely.
Thank you. There's a frequently asked questions. Obviously, it's not solved yet. The question is, until what age do you do a complete percutaneous tenotomy, as it seems working even in older kids? It's to all the speakers. Adjunct, you want to comment on this?
Well,
Complete percutaneous tenotomy until what age?
I think that's really, of course, a complicated question, because there are all kind of situations and all kind of schools where they perform a complete tenotomy. So as Dr. Herzenberg already told, when you have done this once and you want to do it a second time, it even gets more complicated and more riskful. And I think that the situation where you are, how do you say it, what kind of patients there are present also makes it really different. Because in the Netherlands, we only do a complete tenotomy until the age of, I think, around 2 to 3 actually. But that is in the Netherlands, where we try to follow our patients as closely as possible. And I can imagine that in other circumstances you can perform this to a later age, as also is stated in literature, where you can even do this for patients at a much older age. But that's not something we are used to in the Netherlands.
Vince,
so this conference, I think it's beautifully put together as a conference. And you know that I kept pushing back when you asked me to speak, because I said, I can't make this scientific because there's no science in this. This is level 6, eminence-based. It's not evidence, it's eminence-based. And all of this is just what we believe. And so if one performs a tenotomy, when there's a lot of baby fat, you don't see the gap, and then it fills in quickly. If a child has lost their baby fat and they're 4 or 5 years old, and you perform a tenotomy, you can feel that gap. It will fill in with scar tissue, but you can feel that gap for a long time. It looks ugly, and I'm not really sure histologically how it repairs. So in the older child, I usually do a Hoke triple cut, just so that even if one of them becomes a tenotomy, I don't see that dimple divot in the skin for a while. And then what John was talking about, I've done posterior releases as well, and I'm waiting for the lightning bolt. But here's the situation. Based on completely no data, if I do preliminary casting for a recurrent or relapsed foot, and I can get the ankle to neutral, I, from just experience, believe that whether I do a tenotomy or a triple cut, almost tenotomy, I can gain 5 to 10 degrees of dorsiflexion, which is what I want. If preliminary casting doesn't get me to at least neutral, at least a 90-degree ankle, I think there's a good chance I'm going to have to perform a capsulotomy. So I'll do an open procedure, I'll Z-lengthen the tendo Achilles, and if I get the dorsiflexion I need, I'll sew it up. I know how to repair Achilles tendons, and I'll go home. But on the other hand, in the ankle that casts not to neutral, I do the open lengthening and I don't get anything, I can immediately go and perform the posterior release and then repair the tendon. So the issue is, and this is the long way back to where we came from, the reason that tenotomy works and the kids make such beautiful tendons afterwards is that we haven't disrupted the environment. The knife goes through the tendon sheath, it cuts the tendon, but the environment is there for the scar tissue to know to form another tendon. Once you perform a tenotomy, if it doesn't work and then you perform the open incision, there's no way the 2 ends of the tendon will know how to make a beautiful tendon again. You've disrupted the sheath. So if you think you're going to have to do more than a tenotomy, based on no evidence whatsoever, I would say open, lengthen Achilles tendon. We know how to lengthen Achilles tendons. And then if you need to do the capsule, then you repair the tendon. It will be a better end result of the tendon than if you perform the tenotomy, opened, disrupted the environment, and hope that the tendon ends would find themselves again.
thank you. It seems to be that people would like to hear a little bit more about how you perform Peroneus longus to Brevis transfer, if you do it at a time or at a second stage, only if cavus develops, is written down here. The question goes to Dr. Mosca and Dr. Herzenberg.
Well, Vince and I talked about this because honestly, I don't think too many other people are talking about this, but what prompted me to get involved, to try this, is the observation that many patients whom I did a TA transfer, when I looked at them years later, they had a very prominent head of the first metatarsal, a very plantar flexed head of the first metatarsal. And they don't complain about it, but I don't like it. I mean, I think it looks bad and it's prominent, and I don't know what that's going to happen to that when they're older. So it just occurs to me that if you remove the tib ant, now you have the unopposed pull of the Peroneus longus. You're going to develop a plantar flex first ray, which is more cavus. So here's the Herzenberg rule, that when you're doing a TA transfer, if you have a cavus foot, you should also do a longus to brevis transfer. When you're doing a TA transfer and you don't have a cavus foot, you have sort of a normal shaped foot, then you don't have to do it. Now, again, this is like Vince said, this is level 6, eminence based. That's what I do. And I think Vince and I do it differently. Vince does his transfer on the lateral side of the foot. I do mine above the lateral malleolus and do a pulvar taft weave.
Yeah, so John and I have talked about this before, and it goes back to the biomechanics. The biomechanics are that in the typical clubfoot with supination deformity, there's no deformity within the calcaneopedal unit. So calcaneopedal unit is all the bones except for the talus. And in the typical clubfoot, there's no secondary deformity. And when the child has dynamic supination and inverts the subtalar joint, inverts the calcaneopedal unit, the first metatarsal is off the ground. Now, and they have sort of a varus hindfoot, and the first metatarsal is off the ground. That's in contrast to the typical cavovarus foot, where they have a varus hindfoot and a pronated forefoot, Charcot-Marie tooth disease, arthrogryposis, all the other reasons for cavovarus. So club feet, typically, like John showed, there's no callus formation under the first metatarsal. There's thick callus on the lateral border of the forefoot. It's a varus hindfoot because the CPU is inverted. And that means that the tibialis anterior is strong and the peroneus longus is weak, because if the peroneus longus was strong, it would pronate the forefoot, as it does in CMT. We see some club feet, and maybe I don't know what percentage it is, but some club feet that have cavovarus. Dynamically, they're supinating and inverting the subtalar joint, but they have structural cavus within the calcaneopedal unit. So then you have to say, I know it's a club foot. That's what my diagnostic code is. But there's pronation of the forefoot. And as John said, if the forefoot is pronated, it's because the peroneus longus is strong and the tibialis anterior is not quite as strong. So then you need to say, well, let me treat the foot, not what I read about. And that's where, maybe with a plantar fasciotomy, but that's where a longus to brevis transfer would take place, because once you move the tibialis anterior over, the peroneus longus that's already stronger than the tibialis anterior is now going to even more forcefully pronate the already pronated forefoot.
We are unfortunately running out of time. We take one last question. Is there any role for a CAFO or AFO treatment after treatment of relapse, is the question. Adjambo, do you use AFO or CAFO when you performed an anterior tendon transfer? Or do you leave it alone?
No, actually, when we do a tendon transfer, we don't use standardized an AFO or an CAFO after treatment.
How about you, Vince and John?
If I'm doing a tendon transfer, it's usually in an older child, and either they've already abandoned their brace and would never readopt a foot abduction brace, or the main problem now is anti-equinus. I'm not worried about inversion anymore. So at least I fool myself into thinking that they'll wear an independent dorsiflexion eversion AFO. I don't know what they really do. I don't have sensors in there. But in the child who I'm transferring at age 4 or 5, or even older 3, I'd rather have them tolerate an AFO than not use any brace whatsoever, like a foot abduction brace.
So in my practice, after I do a posterior capsulotomy, I cast them for 3 weeks and then they're out of cast. But I save that cast and we make it into a nighttime splint. So at nighttime when they're lying, they're not lying in plantar flexion, they're lying stretched out. But during the day, I rely on the fact that they're walking and they're stretching out their capsule that way. So I do use a posterior splint for as long as they fit into it. It's usually for about 3 or 4 months. and then by that time they're on their own. In my practice, I do KFOs as a fallback for the child that won't tolerate the boots and bars. So I start with a standard solid boots and bar. For the kid who rejects that at the age of 2 or 3, they sometimes just have it, they're ready to throw it out the window and no one's sleeping. Then I'll go to the articulated boots and bar. And if they don't tolerate that, then I go to a unilateral KFO.
Thank you.
Okay, unilateral KFO, but not the, I don't want to use, there's an acronym. I'm not going to sell any device, but there's some company that makes a device with springs from the UK. I found that to be completely doesn't work.
I think to the ADM, but that's a AFO. If I have a kid who rejects the boots and bars, then they go into basically I make them a Poncetti cast out of fiberglass. I bivalve that. We finish off the edges, add Velcro straps, and they sleep in their Poncetti cast every night, either unilateral or bilateral, depending on who they are. So there's just a certain number of kids who don't want their feet tied together. And so by having a Poncetti cast that's been bivalved and fabricated into a brace, you can get more brace wear out of them.
Ariambo, do you use that device from the UK on the springs, the ADM?
Use it in very rare cases, but not on a regular basis, actually. I would like to take the opportunity to ask you both a question, because I was wondering, do you see any future in how to get to some more evidence-based treatment for the relapse club feet? Because I really would like to try to get out of the, of course, very valuable expert opinion and maybe enter a new area where we can get a more evidence-based treatment of those patients. Do you think registers are a good way to get there, or do you think it's better to make an expert panel, or what is your opinion about this topic? How can we get to a more evidence-based treatment of these patients?
Well, I think there's such a common diagnosis. Even the person with the busiest clinical practice cannot answer these questions. It has to be multi-center studies. They can be international. I mean, you can only get so big with a group, and then the data can't be done. But there could be a European group, there can be a group from some country in Asia, the US, but there has to be multi-center studies of people who treat a lot of club feet. First do Delphi panel studies, see what is believed to be known, and then from there develop prospective studies. Registries are going to be important, but they have to be multi-center studies. No single busy practitioner can possibly answer these questions individually.
We have to work on this in the future. Thank you so much to all three of you for contributing and for getting up so early concerning you two in the US. And thank you, Adjambo, as well. John, you wanted to make the last comment?
No, I would say that the future is the two young ladies here. Us old guys, we're kind of done, So the future really depends on you guys, the young folks, to come up with the answers, because there's still obviously many questions to be answered.
We're going to do it together with you. This might be the best. Thank you so much. And thank you, the audience, for listening and being with us. Have a great afternoon and have a great day in the US. Thank you so much. Bye-bye.
Thanks.
Bye.
Bye-bye.